Hello, my name is Matthew Antonucci, and I want to thank you so much for joining us at this lecture for the World Federation of Chiropractic. My lecture is titled Functional Neurology, an Emerging Theme in Healthcare and Chiropractic. This is the second part of a two-part series, the first part being taught by my colleague, Dr. Igor Dykers. And this was prepared for the World Federation of Chiropractic Congress in September 2021. Once again, I said my name is Matthew Antonucci. I'm the Chief Clinical Officer at Plasticity Centers in the United States. I'm the President of the American Board of Brain Injury and Rehabilitation, Professor of Neurology at the Carrick Institute for Graduate Studies, and I'm also a member of the University of Central Florida College of Medicine's Dean Society, and I'm proud to be so. And I'm also proud to be here today with you. So one of the things that we want to talk about today is really what is functional neurology. My colleague, Dr. Dykers, also kind of touched on this a little bit. So the American College of Functional Neurology in 2021 stated that functional neurology is a healthcare specialty in a field of study that focuses on assessing and quantifying neurological activity and utilizes sensory, motor, and cognitive evoked potentials, and in some cases nutrients and pharmacotherapy, to promote normalization and optimization of neurological health. So what does that all mean? It essentially just means that functional neurology aims to assess brain function, to identify where it's deficient, and then also utilizing sensory, motor, and cognitive activities to improve neurological function and optimization, regardless of the neurological or condition. So part of that's really important to recognize is that this functional paradigm is pervasive throughout healthcare right now. Originally, we kind of embraced this traditional model of care, which traditional neurology kind of looks at it as everything is black and white. Either you have a disease or you don't. Kind of like medicine, right? Functional medicine says if you have blood sugar of 130 in United States terms, you have diabetes. If you have it at 120, you don't. That doesn't really make sense to a lot of people. That line can't be that black or white. Where the functional medicine paradigm says if you have a blood sugar of 120, you're almost at diabetes. Can we do something about that before you actually get it? So how that kind of works in neurology, let's just say that somebody walks into your clinic and they've got a stoop posture, they've lost their facial expression, they have a hard time digesting their food, they're kind of cranky, they don't have any tremor, and their balance is not all that bad. They wouldn't be diagnosed with Parkinson's disease just yet, but they're clearly on their way to becoming diagnosed with Parkinson's disease. So functional neurology looks at that and says, okay, before we actually get the diagnosis, let's see if there's anything that we can do to improve this individual's quality of life, as well as maybe turn back their condition a little bit. So there's three components of functional neurology, and it's a multidisciplinary healthcare field and study of practice. We have the assessment and quantification, we have the utilization of evoked potentials, and we also have the promotion and normalization of neurological function. Those are the aims of functional neurology. And to understand where this all comes from and where the sensory, motor, and cognitive evoked potentials come from, we really need to understand a little bit more about why we have a brain. To me, I think that if you have to work with a patient, you have to help a condition, I think you really need to understand the condition to its core. And to understand a condition, you really have to understand the organ, and understand the organ of the brain, we really have to understand its purpose. So what we see here is that the brain's sole purpose is to perceive the environment and create a response that will promote survival and reproduction. A lot of people may try to disagree with this, but I haven't found anybody that gives a compelling argument. So the realistic aspect of this is that whenever your brain is not working well, you are not performing as well as a human being, and the job of a human being is to survive and to pass on its genes. And a great example of this would be someone, let's just say maybe with autism spectrum disorders. They're clearly processing the environment perfectly well. They are able to walk and talk most of the time, but sometimes they are not able to interact with other humans very well. So their sensory signals are bringing information to their brain, they're processing that, and they're creating an aberrant response. I had a patient one time that was a perfectly normal kid unless he was around his grandma, and if he was around his grandma, then he would punch and bite and kick her, and that is not there to promote his survival, especially because his grandmother was his main caretaker. So if his grandmother got fed up and just said, hey, you know what, kid, I'm leaving you on the side of the road, obviously his survivability and his reproduction would be harmed. So that's a decent example of what we talk about when we say that the main job of the brain is for survival and reproduction. If you change sensory information, you change cognitive and motor, which then changes sensation again. So this is a loop. And what we see in this diagram here is at the bottom it says sensory inputs goes into the thalamus, and we've got projections from the thalamus to the cortical motor systems, which are voluntary motor systems, sensory motor cortex, which allows us to feel, experience things, and also the frontal cortex, which allows us to make decisions on how we want to do that. And all of those project back to a part of the brain called the basal ganglia, which are kind of like at the regulatory center of our brain, which then regulates the thalamus, which then changes our perception and changes our motor output. So you kind of see this is a cycle. And if you the only input to this cycle is through sensory inputs. So one of the things that we will see all the time, over and over again inside of neurology, is things are sensory based. So now we need to kind of figure out in functional neurology, how do we assess and quantify decompensation? So this term decompensation is going to be really important to understand. And decompensations usually create diseases, but we have to understand that we're treating decompensation, so therefore we're treating patients, not problems. To say it differently, we don't treat diagnoses, we treat patients and their dysfunction. So when function's not normal, it's called a neurological decompensation. Now, a neurological decompensation is not a new term. This term has been around since like the 1960s. We've heard about it for a long time. And decompensation is defined a couple different ways. One of the ways it's defined is an inability of an organ or system to maintain adequate function. So in the event of the brain, when we see that the brain is able to function but not as well as it should be, so if we know what normal is and it's subnormal or suboptimal, then we can say it's decompensated. Another definition is a failure of an organ to fulfill its function adequately. And another definition is any failure of homeostatic mechanisms. So when we start looking at these decompensations, we can clearly realize that it's going to affect our health. If we're not functioning at an optimal level, these decompensations will reduce our health. So what causes a neurological decompensation? Well, there's so many different things, and you have a list of them here. But in the functional world, where we're talking about things that are not ablative, we're not talking about stroke in this situation, we're not talking about things that you can see on MRI. The two major types of or causes of decompensation are the last two, diascasis and disafferentation. I'll start at the bottom. So disafferentation, what disafferentation is, it's a paucity or a decrease of sensory information to the brain, causing long-term changes in the brain. So a good example of this would be like if I had a cast on my arm, and that cast is not allowing me to move my arm, therefore the joint position receptors, the proprioceptors, are not allowing information to get up to my brain, and we're actually going to see changes in the brain. There's actually a lot of studies that show low back pain actually causes gray matter atrophy in the sensory cortex and the sensory motor cortex of the brain. So that's an example of disafferentation. Now, diascasis is more inside the brain, where there's two areas of the brain that are connected to each other in function. One breaks and it causes changes in the other. So those are two really important aspects of decompensation that we need to understand. Now, can decompensation be measured? Absolutely, and advanced imaging is making it very possible. So what we see here is a couple different types of imaging. On the left side of the screen, we have MRIs, PET MRs, and some statistical analyses of those. And on the right side, we see functional MRI. Now, what this is really cool to see is on the left side of the screen inside the black box, you see in the top left-hand corner in A, that person has a big lesion in their frontal cortex. This is a hematoma that has developed, probably a subdural hematoma that was caught on MRI from a patient. They did a PET image on that guy, and then they see that you can see where the decrease in uptake is in that area of the brain. You see that by blue in that grayish area. And then we also see that there's areas of increase and decreased uptake marked by red and also by blue. Now, the important one to look at here is the bottom right-hand corner. That is a statistical analysis of the functional imaging got from the PET MRI. And what that actually shows is in that top, in the same exact spot where that hematoma is, you can see there's a decrease in brain activity. But what you don't see in the others that you do see in the D, and the statistical analysis, is all of the decompensation as a consequence of the brain injury. All that blue area is decompensated brain regions, and that's causing that individual probably have a lot of symptoms. And on the right side of the screen, we're going to be talking about something completely different. On that right side of the screen, you're going to see the functional MRI images from a study that looked at MTBIs in college football players. Now, these are concussions essentially, and in these concussions, there are no changes on MRIs. You can't see them on MRIs. You can only see them on sophisticated imaging like functional MRI. So what we see here on the right side of the diagram, you'll see that the control group has some areas of decrease or changes in uptake. I would say deviations in their activity. But on the left side of the screen, you see the concussed group. You see there's a whole lot more deviation away from normal function, particularly in the frontal lobe, some in the parietal lobe, some in the occipital lobe, and then in slice Z28, you see the cerebellum. That right cerebellum has a whole lot of decreased function or deviant function. And we would expect that individual to probably have some sort of cerebellar signs. They may have difficulty with coordination of their right extremity or their right lower extremity, or maybe balance where they fall to the right, or they might have vestibular changes, or they may even have some cognitive affective disorders where they have a difficulty regulating their motions or sleep-wake cycles or focus and attention. So these symptoms could be across the board, because what we're looking at here is not a focal area of the brain that's injured. We're looking at a diffuse decompensation that occurs with concussion, and that's where that's so neat. So the next question is, what did we do before imaging? Well, we can learn a lot from Jean-Martin Charcot, who was essentially the father of modern neurology, who his methods, which he basically pioneered the neurological examination, is still being utilized almost a century later, more than a century later, I should say. So Professor Charcot gathered extensive data through clinical observations, including changes in patient statuses, both clinical signs and symptoms, and then correlated them with findings on autopsy. So Professor Charcot was one of the first people to observe his patients, examine them. He was the father of the neurological examination, and then document those. And he had the ability to, after these patients had expired, he was able to do autopsies on them and realize that areas of their brain had changed that correlated with examinations. So what this means to you is that he was the pioneer that said we can do an examination that then represents brain function. So that's what functional neurology is really seated upon. We use functional imaging to validate some of the things that we are trying to prove, but realistically, the core of what we do is a physical examination. Some other things that was interesting about Professor Charcot: he was the first to identify that neurological symptoms can arise from trauma. Before this, it was most neurological symptoms were thought to be psychiatric. He was one of the first physicians to set up rehabilitation clinics for the treatment of his neurological patients. And the treatment included things like vibrational chairs and helmets, which was pretty interesting. The vibrational chairs, he used them on Parkinson's patients. And he would notice that the frequency of their tremor, they usually have a 4 to 6 hertz tremor. He'd put them in these chairs, he would vibrate them. Their tremors would decrease, their balance and gait would improve, and also their sleep would improve. So when Professor Charcot passed away in 1893, the vibrational chairs kind of went away, but now they're reemerging in the 21st century, the vibrational therapy. So it's kind of neat to see that. Here's a great picture I'll share with you. Neurology started as functional neurology. There were no medications for neurological conditions, so everything that was done in neurology had to be done through physical medicine. So this is a classic picture that you can actually see in museums. And we see Professor Charcot standing there with his cigar in his hand. He was a big smoker and he loved food, and that eventually caused him to have heart failure, and that's how he passed away at the early age of 60-something. But in this picture, you see a woman, a beautiful woman with a dress on, who's kind of laying in this man's arms. That man is Babinski, so you heard of Babinski reflexes and Babinski signs and things of that. That is Babinski. He was one of the favorite students of Professor Charcot. And also in the audience there you see Dr. Freud, who's the father of psychology, and Gilles de Tourette, who identified Tourette syndrome, and James Parkinson's. Some of the titans in neurology studied under Professor Charcot. And he would hold these forums or these grand rounds where he would bring these patients in, he would examine them, and what he would do is on the spot try to either fix or exacerbate their condition to show that a physician can either induce these conditions or they can cure them so that they weren't psychiatric. And this all came at a time where a lot of this was actually thought to be psychiatric. So what they would do is they would take these women, because it was largely women, they would say they had hysteria, and they would perform hysterectomies on these hysterical women. That's where the term hysterectomy came from. They would remove their reproductive organs. And Professor Charcot thought that was absolutely absurd. So what he did is he actually found men who were, quote unquote, in the research, manly railroad workers that had traumas that also had hysteria. And he proved everybody wrong that this wasn't a female condition, and the reproductive organs didn't need to be removed. And he tried to hypnotize them and use different types of sensory stimulus to help them break these hysterical patterns. And actually, these trauma-induced hysteria were the first functional neurological disorders, as we know now, which bridges the gap between physical and mental, or I should say neurological and mental health. So, and when functional neurology or functional imaging isn't an option, what we really have to look for is normal function, observed function, and when we take the observed function away from normal function, we understand what the decompensation is. So the really important point of this equation, if you will, is that in order to know what decompensation is, you have to know what normal function is. So observation is a huge thing in functional neurology. We need to observe what is normal. We need to observe what's not normal. We have to comprehend the difference between those two things so that we can then start to help our patients. Now, there are 3 systems of neurological function. This is kind of neat because what this says is that you only have 3 possibilities for a patient to have a problem in neurology. It's either going to be a sensory or motor or a cognitive problem, and they're all related. Sensation is at the seat of all neurological function, and when we sense something, we think about it, we create a motor action. We have a motor action, it changes the way we feel, which changes the way we think, which changes the way we act, and this is cyclical. So when there's a decompensation in any of these 3 systems, it affects all of the others. And this is where patients can literally and figuratively spiral out of control with their neurological conditions. How do we know that sensory came first? Well, there's a lot of studies, a lot of them done out of Harvard, that showed in developing children that sensory pathways develop first, then language, which is a cognitive motor pathway, and then that develops second, and then higher cognitive function developed third. So when we start looking at sensory systems, what we really need to be able to identify is, what are the sensory systems and how do we test them? So many of these sensory systems you know a lot about. A lot of them you were taught in chiropractic school, in medical school, in physical therapy school, how to assess them, such as things like tactile sensation, 2-point discrimination, vibration, light touch, pain or pinwheel. Those are the ways we can test tactile information or sensory information. Then you have proprioceptive, where we look at joint position sense, taste. You have different types of tests you can do. Vision test, we can look at color blindness, we can look at visual acuity. Smell, you have like the UPSIT test, which is the University of Pennsylvania smell identification test, really big and widely used right now for COVID comorbidities. Auditory, you can do sound testing, and then there's also lots of vestibular tests that we can do. The motor system, we can test it a little bit differently as well too. The motor system is built on a hierarchy with involuntary function at the bottom and the most complex voluntary functions at the top. So we look at autonomic function. This is blood vessels, heart rate, neurological reflexes, survival reflexes such as primitive reflexes and things of that nature. Purposeful movement, like being able to tap your fingers, move your hands, and then coordinated movement like gait or speak language and things of that nature. And then on top of it, on the pinnacle of the pyramid, we have behavior. So behavior is kind of a culmination of all of the different motor functions and sensory information together. So what we actually look at is, in this pyramid, we need to have the things at the bottom in order for the next level to start working. And at the top of the pyramid, that behavior is the ultimate confluence of both sensory, cognitive, and motor function. And that's what allows us to kind of function every single day in the world. So I would suppose you would ask, how do we test cognitive function? I have no disclosures to offer, but we utilize Cambridge Brain Science, and they have lots of tests that test all the different areas of the brain and their functions, so that we can now assess a function, and we know what areas of the brain are not working so well, so we can start creating different types of therapies that might be effective for them. So what type of interventions can we do to help people with functional neurological challenges? And to really underscore this, we have to always start with sensory receptors. So I guess the big question is, why do I have these three things on the screen here? Why is it that we are looking at we're looking at batteries, solar panels, and microphones, and how do those things play together? So the way they all kind of come together is batteries work on chemical transducers, solar panels are photic transducers, and microphones are mechanical energy transducers. So all of those take things, potential energy, and turn them into actual electricity. And that's what our nervous system does. Our nervous system takes environmental stimuli and turns them into electricity so that we can perceive them. So one of the things we're looking at here are the different types of neurological receptors. So we have vision, touch, smell, hearing, taste, and we have versions of those for each one of the special senses, like proprioception and vestibular input. And each one of those receptors has a primary, secondary, and tertiary region. So here you see the primary sensory area, the primary auditory area, the primary visual area, as well as their secondary. So to kind of simplify this a little bit, every receptor travels through a nerve pathway to a certain area of the brain. When that sensory receptor becomes activated, it creates an electric potential that goes all the way to the brain, to the cell in the nucleus, creates protein, and now that cell becomes better at doing its job. So that's how sensory stimulus can actually change brain function. So what type of stimulus are we looking at? Well, for example, here's we're going to use light and vision therapy. So we know light and vision therapies in the occipital lobe. Here's a couple PubMed papers for you guys. And I also did a literature search just to kind of out of curiosity on visual stimulation on August 31st, 2021, and 91,956 papers came up for visual stimulation. So when somebody says there's no research on functional neurology, they're just looking for the wrong thing. For example, if you go online and search, do a PubMed search for traditional neurology, you're not going to find any papers. If you do traditional medicine, you're not going to find any papers. So what would make you think that you would find papers on functional neurology? You're searching the wrong thing. You have to look at the components of functional neurology to understand whether or not it has a research basis. So here's an example of some vision therapy. This is kind of neat. This is a combination of vision therapy and also central vestibular therapy. So when you look at the center of that pinwheel, keep staring at the center of it. It's going to stop in a second. And watch what the pinwheel does afterwards. Do you see it rotating the opposite direction? That's because your brain was processing that movement as you moving, and when it stopped, you had a counterproductive response. So that's a good example. We can also use something called visual evoked potentials. So this checker screen on the right-hand side here, we can actually make that checker screen flash at a certain frequency with certain colors to help evoke changes in the visual cortex. Now, we didn't make that up either. Visually evoked potentials have been something that have been around for a while. Typically, they're done on a certain type of test called a P100 test, which tests the visual pathway. So we shine these checkered flashing lights in somebody's eyes. We use electrodes in the back of the head, and we time how long and how much information gets to the occipital lobe. So by the fact that we're creating electricity in the occipital lobe, we know that we're creating action potentials. Therefore, we can create some changes in the occipital lobe by doing that. So next thing we're going to talk about is olfactory therapy. So this is in the temporal lobe. There's a couple papers there for you. Literature search showed 7,277 papers on olfactory stimulation. So things like essential oils, and there's a whole lot of research on mental capacities, emotional capacities, performance, sports performance. There's a lot in psychotherapy and memory and studying for olfactory therapies, but we can use these on our patients as well too. Kind of running close on time here, so we're going to have to kind of hurry up. Somatosensory therapies, parietal lobe stimulation. There's 16,976 papers on somatosensory stimulation, and chiropractic is one of those. Auditory therapy, we can play different types of sounds to different people for different purposes. 58,000 results on PubMed for those. Vestibular therapy, where we're affecting the parietal insular vestibular area. There's 14,000 hits on PubMed for vestibular therapy. So here's a good example of somebody doing some vestibular therapy, activating their vestibular canals, looking at a target. Here is a piece of technology that we have at our facility that allows us to put people inside of this and move them with whole body rotation, which is a bit different than doing the traditional vestibular therapy. So we're very fortunate to have some of that technology with us as well too. And then we also have cognitive rehab. So remember earlier we talked a little bit about how Cambridge Brain Science allows us to target different areas of the brain so we can prescribe therapies. Well, this program that we use is a free program. I've got no affiliation with them or any disclosures. This program that we use called Peak Brain, it's native to the iOS store. You can get it for your iPad or your cell phone. It's really great because you get to pick and assign the different exercises you want your patients to do. And they can start doing these cognitive therapies as well too. And I'll show you what that looks like. So here's Peak. This is what the screen looks like. This is what the game looks like. And it's called Peak Brain. So all in all, in my presentation, we found over 150,000 articles in the peer-reviewed literature on just the topics of this presentation. So one of the things that we kind of talk a lot about is whether or not functional neurology has any evidence to support its existence. And just in this presentation alone, just by searching some really specific keywords about functional neurology, we found over 150,000 articles in the peer-reviewed literature. So, I think that this is a good way to understand what functional neurology is, how it's implemented into practice, how you can implement it with just very simple tools in your practice, just with a brief understanding, as well as kind of a little bit of the research basis for it.